Building Resiliency in the Primary Care Home Team. Before we get started with the presentation, I'm just going to go over a couple of logistical items. So there are lots of you on the line today and more gathering. So we do have a couple of chances for you to chime in during the presentation and ask questions. But for the duration of the presentation, everyone will be on mute. If you do have questions, you don't need to wait until the end. You can type them into the questions pane of the GoToWebinar control panel. The presenters are also going to go through a number of handouts throughout the presentation, so I'm just going to go ahead and use the chat box right now to send a link to a PDF version of the handouts. We've put the handouts up on the website, so you should see a hyperlink pop up in your chat pane. The handouts are embedded into the presentation, but if there was any reason that you wanted to look at them on a PDF separately, you could do that using the link that I just sent out, and then I'll send that out again later in the presentation for anyone who has missed it. The handouts along with the slides are available on the website, as will a recording of this presentation once we're done with it today. That's the one question I can anticipate most people have. So before I turn things over, the Patient-Centered Primary Care Institute launched in 2002 as a public-private partnership between the Oregon Health Authority, the Northwest Health Foundation, and Quality Corps to offer technical assistance, training, and resources to practices that are working towards the patient-centered primary care home model of care. So last year we hosted a series of learning collaboratives, which we will be doing again this year, launched the website, and then offer at least monthly webinars. And then are also about to launch a series of online learning modules about the 2014 PCPCH standards. So do look out for those and information about those to come out in the coming weeks. You can get more information about the PCPCH model of care, which we'll reference during the presentation today, at their website, which is linked at the bottom, primarycarehome.oregon.gov. All right, I am going to briefly introduce our two presenters. First, we have Patricia Robinson, who has explored integrated care from the perspective of a clinician, researcher, trainer, and healthcare consultant for more than 20 years. She's worked on behavioral health integration with providers across the country, including through the Bureau of Primary Care, the Air Force, the Navy, Kaiser Permanente, and various city and county health departments. She's an author. She's literally written the book on behavioral health integration. Some of the items from today's presentation come from some of those books: Real Behavior Change in Primary Care, Behavioral Consultation in Primary Care, and Brief Interventions for Radical Change. Dr. Deborah Gould is an Associate Clinical Professor at the University of Washington in Seattle and board-certified family physician licensed in Washington. She's been practicing family medicine and teaching medical students and family medicine residents for 20 years. She has a medical degree from the State University of New York at Buffalo and completed her family medicine residency at Highland Hospital. She also completed a research fellowship and a master's in public health at the University of Washington in Seattle. She currently works at the Central Washington Family Medicine, a residency program embedded in a community health center in Yakima, Washington. Her interests include evidence-based practice, mental health issues in primary care, community medicine, and practice-based research and physician wellness, which is some wonderful insight she's going to bring to the presentation today. I'm going to go ahead and hand things over to Dr. Robinson to get us started with an outline of the presentation today.
Good morning, and thank you all for coming online so early. I look forward to talking with you this morning with Deb about some tools that we developed. They're from our book, Real Behavior Change in Primary Care. These are tools that help you look at your level of burnout, or spoken in a more positive way, your level of resiliency. Identify also the sources of your stress as you go through your workday, and give you an indication of the magnitude of the stress in various areas. It really pays off for us to pay attention on a regular basis to how different circumstances in our work environments are affecting us and do something about it. The third tool that we're going to mention is a measure of psychological flexibility. So we'll talk more about what psychological flexibility means, but you'll have a tool that you can complete in about 2 or 3 minutes that gives you an idea how you're doing. Our level of psychological flexibility varies somewhat day to day, but we can cultivate habits in our practice routines that promote more flexible responding. Because this is a brief presentation, 1 hour, our effort will be just to describe these tools, and Kate has sent them out in a PDF so that you can look at them as we go through the slides today. Your work will start after the presentation in terms of using these tools and applying them to your life. The other thing we're going to do today is briefly describe 6 core processes that really support clinician resiliency. And we're going to talk briefly about specific exercises that might help you develop more resiliency among the team members on the primary care home.
Hi, good morning. Thank you very much for this opportunity to talk with you all. What we all know is practice redesign is really stressful. I can't tell you how many times I've wanted to throw my computer out the window, but have been able to not do that because of building some psychological flexibility. We know from the National Demonstration Project sponsored by the AAFP that one of the main characteristics that successful practices had was adaptive reserve, and that if the practices didn't have adaptive reserve, they were less likely to be successful in implementing the primary care medical home model. So what's adaptive reserve? Well, adaptive reserve is healthy relationship infrastructure, it's alignment of values and management models, and it's facilitative leadership skills. And all of these skills are really relationship-based. So in order for a successful primary care home team to function, we need to have relationship skills and flexibility with each other. Some of these characteristics I've listed here include valuing your role as a team member, not just going to your job as a job, but being excited about being part of a team, being self-aware, knowing what your communication style is like and what your attitudes are like and how they can affect the rest of the team, being able to think clearly and balance and prioritize, and then once again using this new model of facilitative leadership to really empower your team to promote change. So from my perspective, you know, adaptive reserve is really about resiliency, both as an organization and as an individual. So what happens is if we don't have the resiliency, we end up burning out. And the literature shows that it's not so much the type of stress necessarily, it's our response to the stress is what contributes to burnout, both as an individual and as an organization. And so the mission that Patty and I are on is really to teach individuals and organizations the concepts and strategies of psychological flexibility in order to be more resilient and effective in your organizations and at home. And Patty will be talking more about how we do this through this model called ACT, Acceptance and Commitment Therapy. And hopefully by learning some of these concepts and using some of these tools, this will contribute to your wellness and your organization's wellness. So why is burnout important? So the literature shows us that burnout is described as a prolonged response to chronic and interpersonal stressors on the job, and it's defined by these 3 different domains. Emotional exhaustion, where you really just don't have any more to give. Depersonalization, where you become very cynical about your experience, and then personal accomplishment. And when you're burnt out, you're not feeling like you're effective anymore in your work. And Maslow Burnout Inventory is a proprietary tool, so we couldn't provide that today, but you can look it up, and you'd have to pay to use it. It's been used in lots of studies, so it's kind of a standard out there. So from an individual perspective, what are the effects of burnout? So the question up there you see is, what do you think the burnout rate is for medical students, residents, and attendings? So we'd like you all to take some guesses there.
So this is Kate. You can submit any guesses you have in the chat box. So for medical students, what do you think the burnout rate might be? Let's see who's awake today. Oh, we have someone who says 15% who's awake today, 30%, 80%, so a lot of varying answers. Some are saying providers at 50%. So we've got a pretty good range there, Deb. What is the burnout rate for medical students?
The answers are quite variable, depending on how many of those three characteristics we use as the measure. It varies a lot. Medical students, 45%, and as they go farther along in their education, they're more likely to get burnout. Residents, family practice residents, some studies show 27%. OBGYN residents, 75%. And then primary care attendings, anywhere from 20 to 65%, depending on the study that you look at. And the significance for this as individuals is that, you know, our coping skills, if we don't have healthy coping skills, we're going to end up overeating, drinking, working, alcohol. We have the same rates of alcohol abuse and drug abuse as the general population. We end up isolating ourselves, depression. Suicide, physicians have higher suicide rates than the general population. And then one of the biggest issues is that we are more likely to leave the profession or say that we're going to change our jobs. So it's a huge implication for the workforce. And then, of course, it has effects on our families. So this is one of the best studies I saw that I've come across in terms of looking at burnout in relationship to working conditions and then physician reactions and actual quality of care. When you start looking at this literature, you find that much of the reports about quality of care are self-reports. So physicians or providers feeling as if they're not delivering as good a quality of care. This was an AHRQ-sponsored study that looked at actual outcomes and abstracted information from patient charts, looking at best practices about diabetes, hypertension, congestive heart failure, and preventive measures. And what was really interesting to me was what they found was that there wasn't any relationship between MD stress and burnout and the quality of care that they provided. That it was a cross-sectional study, so the bigger correlation was between the work conditions and the physician reactions. And so what they showed was that when people felt like they had less control over their work environment, so just having to see too many patients in a short amount of time or very complex patients in a short amount of time, and also particularly when providers didn't feel like the missions of the providers and the overall organization didn't match, this resulted in low satisfaction, high stress and burnout, and the big issue there is the intent to leave the organization or leave their job. And one of the studies I've read, it costs around $200,000 to $250,000 to replace a family physician. The burnout level in this study was 26%, and it involved all different kinds of practices, solo practices, group practices. the Midwest and the East Coast and rural areas and the cities. So I really like this study.
Okay, so here is a tool that I think is useful to the individual primary care provider, but also I think important for medical leaders as well. This is our primary care provider stress checklist. It offers respondents a chance to assess their level of stress in 6 different areas. First is the area of interacting with patients. So to what extent is interacting with patients who don't manage their chronic disease stressful? You simply rate the level of stress from 0, not stressful, to 6, extremely stressful. Many times primary care providers are okay with chronic disease, but they struggle with trying to address the needs of patients who are addicted to alcohol or to drugs, or patients with chronic pain who are seeking narcotics. Also, angry and demanding patients can produce a lot of stress for people, all people, not just primary care providers, but all members of the patient-centered medical home. So that's the first area, and often one of the highest areas of stress in a primary care provider's experience. But also important is the next area, which is practice management. Having a really tight schedule, feeling like your patients are waiting too long, hearing complaints from your patients about having to wait too long, not being able to quickly access maybe the information needed for various medical activities with patients, and just dealing with a lot of interruptions and annoyances during the clinic day. Another area is just the many administrative issues and our busy practices. Also, the level of education and learning necessary on a day-in, day-out basis. This is a field where information is coming in daily. I think primary care providers, I read one study years ago saying that primary care providers receive more mail about educational kinds of things than any other profession in the United States. So it can be really maybe not always noted the impact, but certainly contributing to the overall level of stress in the primary care provider's life. Relationships with colleagues, as stress mounts, can make it more difficult for us to relate with our colleagues, and so much of our work is team-based. And the final area is that of kind of looking at our balance between work and what Deb and I and Kirk called the rest of life. So what is that balance, and to what extent is it stressful for us to try to maintain that balance day in, day out? So higher scores indicate more stress, and there are the scores for each of the 6 skills, and then there's a total score as well. What I recommend is that primary care providers in the practice complete this, and then that the results be summarized, not indicating the specific providers, but summarized and considered by the medical director, if not the group, to look at the variation among providers in the clinic in terms of the level of stress on the specific scores. This can certainly help medical directors and other clinic leadership identify common kind of sources of stress and really target those. And it can also see variations. So what are there outliers in the level of stress? For example, in that first area, interactions with patients, in some studies we've looked at, we'll see that primary care providers that, for example, are not using resources like behavioral health consultant services, their level of stress and interacting with patients may be higher. So back to you, Deb.
Actually, Patty, it's okay. So this is one of the books that's been recently published by Flaxman and Bond. Frank Bond is a psychology professor in the United Kingdom, and he has done a ton of work around using the idea of psychological flexibility and acceptance and commitment training or therapy as a way to help improve the effectiveness of organizations and the vitality of life for individuals. And it's been really great because he's compiled this, and it is a 3-session. Basically, he did a study looking at 3 sessions of ACT training with government workers and showed that there was improvement in people's, that there was less burnout with individuals who'd gone through the training. And they've also shown that people were better at their jobs, that they were more able to learn new skills and apply those skills compared to people who haven't gone through any kind of acceptance and commitment training. So this would be a really great resource for your practices and administration to look at and consider organizing a series for your offices. I talked a little bit already, a little bit about the evidence already. The second study mentioned here, substance abuse counselors, was a key study done by Stephen Hayes. And what they looked at was it was a randomized controlled trial that compared an arm of multicultural training where patients learned about avoiding stigmatizing and learning about families and cultural context. And then that was compared to an ACT mindfulness and values training versus a control group that was really learning just about the biological effects of methamphetamines and alcohol, etc. And what they were able to show was that the folks who participated in the multicultural training had less stigmatizing attitudes right after the training. The ACT group not only had less stigmatizing attitudes after the training, but also about, I think it was 3 or 5 months after the training, they had improvements in their burnout scores also. So it seemed like the ACT group had more sustained effects. There's other studies that are looking at more just mindfulness. You'll see with ACT that ACT is really about mindfulness and values, and so it's a little different from just straight mindfulness training. There was a study done in Rochester that was quite extensive in terms of the number of months involved in the continuing medical education. But they did find improvements in burnout and empathy and emotional stability in physicians who had participated in this mindfulness communication training. And then the last but not least was the fact that in the third study at the bottom shown there, the patients themselves described having a better experience with psychotherapists who had actually gone through a mindfulness training. So I think you're going to see a growing body of literature eventually in the medical community about how psychological flexibility is going to improve people's performance and their quality of life. Okay, Patty.
Thanks, Deb. So it's a matter of what can we do about this problem of stress in our work lives, and what can you do even today to help you better address stress. And the research suggests it's limited in terms of how much we can just kind of eliminate or reduce the stresses that impinge upon our work lives every day, but we can work on processes within ourselves and strengthen those processes so that our overall resilience is better. This is what we call the hexaflex in acceptance and commitment therapy, and these are the 6 processes that we found to be associated with psychological flexibility. So that's the goal. That's the overall product we're going for that's going to make us more resilient. So let's take a look at the individual processes and then chunk them into 2 groups for later recall. The first process there at the top is the ability to be present. So many times when we talk about being present, we find it easier to talk about kind of tuning in to one single kind of experience. It might be something external, like looking at a picture on the wall or an app on your computer, or on your smartphone. One of my favorite ones, by the way, right now is called, it's by it's Luminescence, and it's Meditation Oasis. And it has this beautiful kind of design that gradually fades to a different design. And it really requires you to be visually present in that moment. You can set it for like 2 minutes or 3 minutes, and it just pulls you into your present moment experience. But doing almost anything, like just concentrating on what it feels like to have a tongue, or the temperature in your feet, can kind of bring you more into what we call the present moment. The present moment is so important to psychological flexibility because that's the space in which we can make a choice to respond in a more intentional kind of way. The next process associated with resilience is being able to connect with our values, and Deb is going to talk more about this piece momentarily, so I'm not going to go way into it, but you'll recall previously when she was talking about burnout that one of the indicators is feeling more distant, less connected to that sense of purpose that led you to pursue a career in healthcare. So trying to find a way to connect with your values, talk with other people about your values, and consider them. One of my favorite sorts of things is just one in the morning, one in the evening, thinking about what am I going to put out front in terms of that carrot for myself, that thing I'm trying to pursue in terms of purpose for that day, and then spend a few minutes at the end of the day reflecting on how'd that go. You know, honestly, some days I forget I even chose something. Other days there's more of a connection. So connecting with values and then acting on values, another group of skills, actually taking action, and sometimes it's a more difficult course that we choose in order to pursue a value-consistent action than to kind of just let it slide and do something less purpose-related, that just kind of works at the moment. Down at the bottom there you see changing self. So many times we get stuck in kind of stories about ourselves that are not very workable, and they're not very fresh. And so we need to be able to kind of shift our perspective on these stories to a different perspective, and to see those unworkable stories, those stories that are not producing the outcomes we want, with a different perspective. It's truly one of the things unique to being a human being, that we can make up so many stories about ourselves, and really the stories depend upon the context that we're in. We'll tell a different story if we're at a cocktail party and we want to become friends with somebody, a different story if we're at a job interview. All of these stories are true in some ways. It's just sometimes we get into stories that are not working in the sense of producing the outcomes that we want. Over on the left-hand side, you'll see diffusion, and diffuse has to do, again, with the way that our minds process language. So it really works for us to be able to fuse with, like, oh my gosh, a car is coming, if we're starting to step out into a street, and we just immediately, we don't have to think about it, we just pull back. On the other hand, sometimes fusing doesn't work very well for us. For example, our computer goes down and we get fused with the idea that nothing is working, this is going to be an awful day, and then somebody comes up and we're grumpy, and it kind of can go downhill on the team from there. So being able to kind of defuse when things that really hook us happen during the workday is very important. And acceptance is accepting what's there, the computer that's gone down, maybe the call indicating child is sick at school, the sense of having too many patients, and somehow or another move forward in a way that is consistent with our values. So we like to group the core processes of resiliency into two larger groups. So as seen on this slide, you can see the rectangle kind of pulling in acceptance and diffusion, along with being present and being able to kind of shift perspectives on yourself, mindfulness. So becoming more mindful in the way that we approach stress. And then in the next slide, you see the other basic area in resilience is being able to use present moment, changing perspectives on self, to better connect yourself with your values and to take action that is value consistent in your daily routines. So this is our tool that provides you with a measure of your overall psychological flexibility at any given moment in time. So 20 items, probably take you 2 or 3 minutes to complete it, and you sum the scores to get your total score. Higher scores indicate greater psychological flexibility. Our recommendation is that you use this tool perhaps on a quarterly basis. To just get an overall estimate of how you're doing in terms of psychological flexibility once you develop a plan to increase it, and then to beef up or continue your plan according to the results. So, Deb, I'm going to give it to you and let you talk a little bit about values.
Patty, you got to click it forward. All right, so values. So values. It's really what matters to you in your life and what you want to stand for. One of the ways that we get at this is a exercise called
Hey, Deb, it's Kate. You're kind of cutting in and out.
Okay.
Are you there?
Yeah, I'm here. Can you hear me?
Okay, there you go. That's better.
Okay. So the tool here is that think about your retirement party, and your family's there, your friends are there, your coworkers are there, and we're all sitting around and kind of appreciating you. Well, what would you like your family members to say? What would you like your colleagues to say about how you led your life? And so the four main domains that we picked in terms of looking at values include practicing medicine, our relationships with colleagues, relationships with family and friends, and then our personal health and well-being. And so this is a really kind of fun way to get at what really matters to you and to connect. As you look back on that hexaflex, it's an exercise to really connect with those values. And once you connect with the values, then you can think about what's going to be the action plan, which we'll get to later on. So once you've figured out what those values are, you can then clarify, well, am I really behaving according to my values? So this is called the bullseye. And the bullseye means if you place an X at the bullseye, it means that you are behaving in a way that is really true to your values and true to yourself. If you X out in the outermost ring, if you place your X there, it means that your behavior is, or my behavior is really inconsistent with what my values are. And this is going to be a place where I can do some work and figure out an action plan to get closer to my values. The farther away from my values, the more burned out I'm going to feel. So I really want to try to get closer to, the bullseye in whatever way I can. So here you see the four domains that we talked about: studying, practicing medicine, relationships with families and friends, relationships with colleagues, and then your personal health and well-being. So, Patty, it's up to you.
Patty, you might be muted because we can't hear you.
Thank you. I had the perfect start, but I'm just going to circle back and say it again. So this is our last tool in this presentation, and I think it's a powerful one. We call it the Burnout Prevention Plan. Our PCP friends, Deb, can testify to this. They say also Burnout Recovery Plan. So whichever way you want to think about it, prevention or recovery, this is the way you go through it. You use your value statement. Really what you're trying to do is select one area from the bullseye assessment that you want to improve. So back in the previous slide, Deb was talking about the different areas, like maybe it's how you relate to colleagues. Maybe it's your sense of personal health and well-being, taking that time to make adjustments in your lifestyle that really promote your health. Or your relationships with family and friends. Maybe you want to get stronger connections, make more time for friends and social activities that really recharge your batteries. Or maybe it's just in your practice of medicine, the way you're going through your day, maybe trying to bring more joy into the practice. So you choose one or two areas, and then you indicate your value statement. What is your value statement there? And next, and this is going to sound very familiar to all of you, you come up with some action steps. And these are the areas we recommend that you write action steps for. First, your practice of acceptance. Are there specific things you can do to practice acceptance? It might be just taking time to sit down for a few minutes and breathe 10 deep breaths, just accepting where you are at that moment in your busy day. There was a TED Talk I recently saw called the power position. Check it out. You might stand in your power position for 2 minutes and take 10 deep breaths. This position apparently lowers cortisol and increases testosterone. So it's like a magical kind of position, and there's a variety of these positions that can promote just acceptance and responding in the moment. A second area is just practice of mindfulness, so that ability to step back, be present, notice that you're hooked, let go of it. And then the third area is practicing value-consistent actions on a daily basis. So a good way to do this is maybe just reflect a little bit halfway through the day. What sorts of things have I been doing that are very value consistent? Is there something else I would like to do this afternoon? I think one thing that primary care providers and people on the patient-centered medical home team are particularly good at that's very value consistent is expressing gratitude. I work in different primary care clinics every week, and what I hear so often is the word thank you. It's easy to do and so helpful in terms of value consistent actions. So something as simple as that could be a part of your plan. We do recommend that you list specific behaviors in these areas, and actually the more specific you are, the more likely I think you are to engage in these activities. You might want to just choose 2 areas and try to come up with 1 or 2 things, and later you can fill out this plan and expand upon it. I do hope you'll take the time later today to get a start on this, because it's really about getting a start and being intentional that's going to help you build your resiliency. So I encourage you to look back at that bullseye values assessment, choose even one area, and then use the burnout prevention plan to come up with some specific steps you can take today. I also think it would be a great idea for you to let other members of your team know what you're working on so that they can better support you. One of the things that I really like is Deb Gould consistently posts her updated bullseye value assessment at her workstation in her clinic. So I think it's a bit of a bold move. I do think it's a step in the right direction in creating resiliency and working towards that important goal on a daily basis, and trusting that other people support you in that direction and that effort. So probably you're wondering, where do I read more about this? Hopefully you're thinking there's some good ideas and some good tools and you want to go forward. So I'm going to have Deb direct you to some resources so that you can learn more in your own self-study.
Once again, you'll see the Mindful and Effective Employee there that Flaxman and Bond just came out with. So I'd recommend that highly from an organizational standpoint. The first book is a book that Patty and I and Kirk Strassel wrote together, and it's really the first book applying ACT to the primary care setting. And we really wanted to make this a very practical book, and so part of it has to do with applying this strategy to working with patients, and then the other part of it has to do with applying it to ourselves. So many of the tools that you learned about today are in that book, and also online with New Harbinger. You'll see a website there, New Harbinger Publications, and you can connect with the tools there. The Association for Contextual Behavioral Science is an organization that is, one of the best organizations I've been part of, because there's really a collaboration amongst researchers, clinicians, and administrators in terms of how do we decrease people's suffering in the world. And it's ACT-based and what's also called relational frame theory-based organization. So it's a contextual, it's a CBT, cognitive behavioral therapy kind of organization that I have found very welcoming to all different kinds of providers also. So you'll see in me psychologists, social workers, physicians, administrators, all types of people there at their meetings. And their website is really useful for getting tools and resources, learning about ACT, and it's definitely an international organization, so that's pretty cool too. Then your own organizations there in Oregon in terms of the primary care or patient-centered primary care home tools. And then, Patty, you know more about Matthew McKay's book than I do, so would you talk about his book?
Sure. I've been hearing really good feedback from that book, about that book, from people that are new to ACT. And Matt is a friend and colleague, and he is someone that has been involved in cognitive behavioral therapy and in dissemination efforts for decades, and is quite committed to getting science into practice. And I think he's done a great job in helping us kind of take the basic principles, and along with his co-author, Patricia Zurita Ona, who is just really, really good with kind of adapting ACT to work with Latino culture. So that was another reason I thought good thing to look at, and useful in terms of kind of some of the more common problems that we see in primary care with patients, but also with ourselves when we're stressed. So feeling nervous, sad, irritable, or angry. So maybe a good read.
All right, so we have just about 10 minutes left to get some questions. So quick reminder, you are all on mute. So if you have questions, please type them into the questions pane on the GoToWebinar control panel. And then I do have a couple questions that have already come in that we can get started with. So the first was about the bullseye tool. So Deb, I don't know if you can speak to this, but the question was whether or not individuals place themselves on the bullseye, or is it just, or is there some sort of numeric rating that goes along with it? Can you talk just a little bit more about that?
Yeah, I mean, you can apply a numeric rating. You can say that, you know, the center of the bullseye is 0, and then the ring, the outermost ring, is 7. So you can quantify it, and I'm not sure, but I think the person who originally created the bullseye may have done studies with it. I'm not sure. But you can quantify it that way. I use it for myself and put myself on the bullseye. Or and the other thing is I use it with patients. So I ask them, if this is your value, where would you place yourself? Do you think you're doing everything you can to be true to your values, or you think you're out here not doing anything? And so you can use it multiple ways.
I'll just add a little bit to that, Deb. The original idea person with the bullseye is Tobias Lundgren, Lundgren, and he's a Swedish psychologist, and he has published, and I'll be glad to send along a reference to Kate so she can put it on the website. And he does recommend a rating scale so that you can measure value consistency. I think it's a wonderful tool with patients and with us providers in terms of looking at just even a little change. And what I tell patients and tell myself when I make a value consistency rating is no one is hitting the bullseye, right? I mean, the bullseye is there as a focus, so it helps us get on the target, and that's really what using the bullseye is about, is having a target, not being perfect and having completely consistent actions all day long. Maybe the Dalai Lama does that, but most of the people in my life don't. But if we can put up targets and describe what the bullseye is, we have a better chance of making choices that get us on target.
Great. So one of the other questions that came in is, are there any current or planned studies using any of the tools that were presented today? So I know you talked a little bit about evidence, and then we presented some of the tools. I don't know, were there some intersections there that you could talk about?
Yes. So exciting. And Deb, you can chime in too. We do have studies in process looking at the PCP stress checklist and the PCP AAQ, and we are seeing a relationship between higher stress and lower psychological flexibility. So we have, I think, one study involving about 50 primary care providers at this point, and there's plans to probably get data from another 50 primary care providers, and then the next effort will be to see how we can change these in response to a 4-hour workshop. So, yeah. We also have other studies looking at, and Deb can speak to this, but looking at the stress checklist and the AAQ tool in residents as they progress through family practice residency training, where they receive training in using acceptance and commitment therapy exercises to promote resiliency.
Yeah, in the residency here, I run workshops both at the beginning of the year and then halfway through the year, using these tools and experiential exercises, learning the different core processes of psychological flexibility. I'm just entering the data now into a spreadsheet, so I haven't really had a chance to look at things over people over time. So we're still in the beginning of trying to get the data together and share the data.
Great. There is one other question to talk a little bit about how non-physician clinic leaders can incorporate these tools into teams or introduce them to clinic leadership, or how have you either done that or seen that done? So for the office managers or others on the phone, how could they start to incorporate some of these tools?
I think it would be a great idea to come up with a version of the stress checklist that works for non-clinician members of the team. I haven't pursued that. I am involved right now in coming up with a version of the stress checklist and the AAQ for behavioral health consultants who are joining patient-centered medical homes throughout the state of Oregon so that they can be more mindful in identifying and responding to the sources of stress that they experience in what is really a new role for them. Great idea. I'll work on it.
Yeah, I think we're really in the forefront of really introducing this into primary care work with patients and for a clinician and organizational wellness. So I think as more studies come out, kind of looking at, well, what's the right number of sessions with our staff that's going to work, we'll be more able to go to our administrators and say, hey, you know, it's only going to take 3 2.5-hour sessions spread over the year to improve people's scores in terms of burnout and their ability to work on a team. So, you know, it's difficult. I know from the National Demonstration Project, one of the things that came out from that is that if the teams just met on a regular basis for like a half an hour to an hour, that it improved the productivity of the team. But many times it's really difficult to convince administrators that, well, you got to take that half an hour out of the clinic time and have this meeting, and we'll have a more productive and effective team. It's challenging, and I haven't been successful at it yet.
Excellent. So if there are any really quick last-minute questions, you can type them in. If not, just a quick reminder that the resources from this webinar and other webinars are available online. So a recording of this presentation, a PDF version of the slides, a PDF version of the handouts, and then also Word document versions of the handouts. The recording of the webinar will be posted later today, and a link goes out to everyone who attended the webinar today. And then there is a post-webinar survey that will pop up after we conclude the presentation today. If you would take that, that's very helpful, helps us as we design webinar presentations in the future. I want to thank Deb and Patty for sharing such great information and resources with us today, and that I hope everyone will be able to log on to the website to take advantage of. Thanks, everybody.
Thanks. Have a great day.
Thank you.